Burnout happens when repeated trauma and usually moral injury results in that permanent damage. And what is moral injury? Moral injury is when you ethically care about something and you have no control when you're trying to do the right thing and you can't do it. So you get this moral injury and it's repeated stress by the systems.
Welcome to the show. We're here because we're curious about medical imaging or have a hunger to learn more. What can we learn from each other, and how should we prepare to tackle the challenges ahead? I'm Chris St. John, and join me today as we rethink imaging, a podcast by Radiologists. Dr. Mina Makary is here with me today. Dr. Makary, thank you so much for being here.
Thank you for the opportunity. I'm really excited to be here.
I'm super excited to talk to you because, I've been doing this show for, it's almost 2 years now, and I've been slowly crawling through all of these different pockets of medical imaging, having had zero experience in the field when I got going. And so I was particularly excited to speak to you today because of your specialty in interventional radiology. And it's funny because, I have had little to no exposure to interventional radiology in general, but it seems to be that is the general public sentiment anyway.
No, it's true. Well, I'm also honored and excited to be here and to connect with you. And you're absolutely correct, Chris. So most people are not familiar with interventional radiology. And, most folks are familiar with diagnostic radiology when they think of radiology in general. And those are the doctors or radiologists who use imaging to diagnose disease. So they get x-rays, CAT scans, ultrasounds, MRIs, and then they interpret them and they arrive at a diagnosis to help figure out what's going on with the patient. Now, interventional radiologists are physicians who do the same thing, but they do it a step beyond that. So not only they use imaging to diagnose, but to actually treat. And as we will discuss today, that's amazing because it opens up possibilities to do big things through minimally invasive and small holes and bigger, better opportunities for the patient. And this has evolved over time, and it's a relatively recent specialty. It was recognized as its own specialty in 2012. And I've done actually studies on awareness of interventional radiology, and lots of, not just the public, but even primary care physicians and even specialists may not always be aware of what we can offer and what we can do to patients. So you're not alone.
Yeah. So, given that most patients have never really even heard of it, I'm curious, about when that awareness gap kind of first hit you. You said it wasn't even a specialty until 2012?
So it was being practiced as a subspecialty of diagnostic radiology. So physicians would do diagnostic radiology residency, and then they would do a fellowship in interventional radiology as a subspecialty of diagnostic radiology. But by 2012, the Board of Specialties recognized that we're so distinct in terms of the way we particularly on the basis of the clinical care. We have our own clinics, we admit patients, we manage them before and after procedures, we're not just diagnosing them, that they recognize that as its own specialty. And as a result, we have our own residency training program, so it's not a fellowship or subspecialty of diagnostic imaging anymore, it's its own specialty. We're still board certified by the American College of Radiology, and almost all of us are trained, are dual board certified diagnostic and interventional, so we can do both. But the specialty has been on even before then, but this was more of the official recognition, a training standpoint and an organizational standpoint.
Yeah. And so, and since then, I know you've done a lot of research on the awareness of it. How have you seen kind of the course or like the growth of the specialty, and how have you seen things change since 2012?
So interventional radiology, or IR for short, has grown tremendously. And the reason is, we have sicker patients, and oftentimes they are not candidates for traditional treatments, or traditional treatments may be too risky or have issues. We also have generally healthy patients with unique conditions that want the least invasive options. So awareness has increased. Before, when it was a subspecialty of diagnostic radiology, the pool of candidates or physicians, they would be ones who are already diagnostic radiologists that would participate in this training pathway. But now, starting from medical school, people can directly apply to interventional radiology. So a lot of medical students, part of the curricula have integrated interventional radiology. Rotations, they rotate in our departments, all sorts of things. And then from the primary care and specialist standpoint, other physicians will see, we send this patient to IR and they have great outcomes and they come back. Or patients, I have several patients that I've offered them something or they learned online that there are better options for treatment and they seek us out. So, once you do good work, I think the message gets out. So I'm very proud of our specialty and I'm really excited about the work we do now and the future that is so bright for what we can offer patients.
Yeah, absolutely. And I want to tie this back into you and your personal history, right? Because I believe you trained and continue to work at Ohio State. Is that correct?
That is correct. So I went to medical school at Ohio State, and I did my internship in another institution, and then I came back for my diagnostic radiology residency. So I was a diagnostic radiologist first, and then I did a second residency in interventional radiology. And then I was recruited to stay here, and I'm a Buckeye through and through.
And so, yeah, I mean, I'm curious about your personal timeline and your time at Ohio State, along with this kind of growth of interventional radiology, because you helped launch an interventional inpatient service at Ohio State. What did that process look like, and where were you? Can you get me a line timeline wise between both you and the specialty, and let me know what happened?
No, absolutely. So, I've been at Ohio State for a long time just because of my, training and staying here. And 4 years ago, I recognized the need for a support team to help us with management of patients. So, um, in diagnostic radiology, the general mindset of the referring physicians is that we're going to order a CAT scan, we're going to order an MRI, we're going to order a test. In interventional radiology, it's more of a consultation because you cannot order an interventional radiology procedure. Interventional radiology procedure has benefits, risks, alternatives. A patient may be a candidate or not a candidate. So we have to, as physicians performing or offering these treatments, we have to evaluate the patient and make a decision in terms of whether they're a candidate, what to expect, how to manage them. Do you stop their treatment, blood thinners, or manage their medicines before and after? So there's a lot of clinical decision-making involved in clinical management and follow-ups in clinic after and before and all this stuff. So this was a huge enterprise. And so what I did is I worked with our hospital system to develop an APP team of advanced practice providers that integrate with the interventional radiology service. And it's an inpatient service that helps with the consults, it helps with our clinic, and it helps with the patients that we admit and follow up. So basically, it's a peri-procedural inpatient team that manages the patients before, after, and during a procedure to ensure they have their questions are answered, they're optimized, their documentation, so we can not just do a procedure, but we document it, we follow up with referring physicians, we manage their medications after, and we set up for follow-ups, and if they have questions, they come and see us. So obviously that's a huge enterprise, and it was a gap that was needed to be addressed. So we worked with the hospital administration to hire a group of advanced practice providers, nurse practitioners, and physician assistants that worked with our team to offer that inpatient service. So it's been tremendous. It really improved our outcomes, turnaround time, patient experience, communication, and is really became the glue that held that care. So I'm very proud of the work that we've done at Ohio State, and it's been recognized even by the ACR and other institutions for its innovative, forward-thinking approach, and it's something that really improved patient outcomes.
Yeah. Did you encounter like any level of resistance or any sort of speed bumps when building this program? Were there like any major challenges in terms of, kind of building this thing from the start?
Yeah, of course, because it's not, anytime you build anything new, this took a lot of work. We created a business proposal to make sure that if the financials are sound and we can bill appropriately. And I worked with, initially you have to get consensus from stakeholders, administration, colleagues, other folks. So I partnered with a diagnostic radiologist when we first started this to get buy-in from our diagnostic radiology colleagues. For some of them will do procedures that need support. In addition, I was covering interventional radiology, and we worked together and we launched that service. But there were quality metrics that we had to develop, education, templates for the notes, workflow, scheduling, and I also partnered with an APP manager and now there's two who are fantastic to HR issues and hiring and all this stuff. So obviously there are always barriers in terms of workflow, culture, funding, recruiting people and recruiting the right people, right? And the people have the mindset of what we're trying to accomplish, team players, hard workers. And then retention. We've had fantastic retention because we want people, once they come here, they're happy to be part of the team and they understand what they're contributing to. And we have a great relationship with all our team members. So it was a lot of work. It's very rewarding, and we were able to put all these factors and address any barriers and build it together. So I'm very proud of it.
Good. I mean, it's fantastic to hear. And actually, I'm going to put a pin in that little retention comment, and hopefully we are going to be able to circle back to it, because you've done some really interesting work talking about burnout versus, I think, moral injury is the term that you use. I want to touch on that too. But while we're still in this IR thread, would you mind just giving me some examples of some of the more common procedures or treatments that you're doing, just so I can kind of understand what you're actually up to some degree?
Absolutely. So like I said, the whole point of interventional radiology is that you can see inside the body to fix patient issues and to address disease. So some of what we do is we open blocked up vessels. We block vessels that are bleeding or causing or supplying tumors. Some of it's we remove clots. Some of it we put devices to protect patients or to give them treatment options. So there are many categories and many service lines that we offer, but in general, we can, for example, starting with the basics, we can provide vascular access. So a patient comes in the hospital, they need an IV. The IV can last for a few days. Patient that needs repeated treatments or dialysis or chemotherapy, they need devices implanted so they can get their treatments. And a lot of times the vessels scar down and they're small and requires expertise in minimally invasive interventions. So IR is generally considered the experts on vascular access. So we do that. And that could also be dialysis fistulas, which are surgical procedures done in the arm that need maintenance, so we can manage those. There can also be patients who need nutrition. They need tubes in their stomachs. It's called gastric tube or GJ tubes. It could be patients who have a tumor or an abnormal finding. They need a biopsy or tissue sampling to diagnose it. We can do that. Those are kind of more of the basics. More intermediate things that we do is more glamorous, I guess, would be patients who are bleeding, and we can stop the bleeding. And that can be, more stable, but it could be also immersion patients, trauma patients, life-threatening, 2 a.m, somebody's dying and they have no options. We can come in, stop the bleeding. You could see on the table, their heart rate goes down. They're doing great. The family's happy. We can save their life. So we deal with bleeding issues. And people with clot or DVT in their legs, let's say you take a long flight, you're not getting out of bed, you get clot in your leg, and select patients, it's appropriate to remove the clot to improve their outcomes. And sometimes the clot goes to the lung, we can clear the lungs. Patients who have cancer, and that's something of great interest to me, we can offer treatments to deliver radiation, to deliver chemotherapy, to deliver other medicines to the tumor directly, so it doesn't go in the entire body, but directly to the tumor. We can burn or freeze a tumor, and the patient can go home the same day, cancer-free, with a Band-Aid. Nothing in medicine can be like that. It's
Crazy.
called an ablation procedure. It's one of the most rewarding things that I do, and there's more exciting things about that I'll tell you about if you're interested.
Yeah, absolutely.
There is pain interventions that we offer to patients. There's liver interventions in patients who have fluid buildup or other things. Patients who have, we work in every major system in the body. Patients who have kidney stones or blockages and they need intervention in the liver and the kidney and other organs. So We are specialists, but we are also so broad in our abilities and our scope. We have the beauty of being able to treat a whole lot of issues at a very high level and communicate with other specialists at that level. So versus, in medicine, there's a dichotomy. Either a generalist, you treat general conditions and maybe not as in depth, in great depth, or a specialist where you specialize in two or three things and be really good at it. IR requires us to be specialists because we are dealing with high level situations and high level management of different diseases. But there's so many diseases that we can touch that we're also broad in our spectrum. But I hope that was a good overview. I know
Yeah,
it's a
no, I
lot
mean
of
it's
much more too, but
I know. I mean, I feel that it's one of those. I forget the term, like the concept that the more you know, the more you realize you don't know. Right? It's just like I felt like with every example you were giving me, the true scale and expansiveness of IR, I feel like was becoming pretty clear. But I want to follow up too, because I believe you take on like very complex venous reconstructions that very often other providers won't really touch them. What pulls you to those cases?
so that is true. One of my interests is venous intervention. And the reason I have built that service line is giving patients hope. And I also enjoy the challenge of these complex cases. And what happens is that most patients, so DVT or clot in the legs, but it can happen in arms or other body parts is common. And there are risk factors for it. Patients who have family history or travel or cancer or even benign, or sometimes you even know or have blood issues, but they're very common. And 50% of those patients, they develop something called PTS or post-thrombotic syndrome, where the clot never clears. The veins get scarred down and they disappear or they go away. And so you could have a very healthy 30-year-old patient who I had Olympic athletes, I have people in tremendous shape who have had an issue, they got a DVT, and 50% of those patients, the clot never goes away. Instead, the vein never opens up after treatment with blood thinners. It scars down and gets clogged, and then they have no flow. So they end up with swelling, redness, pain, all sorts of issues, and it's very disabling. By 10 years, most patients are disabled and they can't work, and there's a lot of downstream effects. So one of the things that inspired me to get in this space is that we want to be able to give these patients hope. And, using the creativity of IR, we have a toolbox of equipment and which is a common theme in IR. You get a problem and folks tell you like, hey, we have this issue. We don't know, we don't really have standard options. Can you figure out a plan for this patient? So we have a toolbox. I love problem solving. We have a problem. So I use different ways, creative ways to build those veins or reconstruct them to give patients options. And obviously, it's part of a medical community and we collaborate with other physicians and we learn from other physicians as much as we share our experience. But that was one of my true passions. It's a need that I recognized when I first started here. And now that has become, thankfully a big service line for patients.
I love that, and it's interesting. I love the driving factor of giving hope and allowing people the opportunities that they're not going to have. But I'm curious about kind of the other side of that coin, right? And how you think about, risk when, you are kind of the last line of defense for these patients.
Absolutely. And that's a fantastic question because risk versus benefit is something that we have to deal with all the time.
It's our favorite subject matter on this show.
Absolutely. Once you once you go into medicine, especially my specialty, you have to weigh in on all these things because we have to think outside the box and give patients options if we're able to safely. At the same time, we don't want to be cowboys and just hurt people. And also, we have to be realistic. We have to know our own, abilities. So I know what I'm capable of in my hands, and I know what my colleagues are. And there's things I'm good at, and there's things other people are better at, and that's okay. I know the limits of my equipment, and a lot of it's is finesse and understanding. It's not just put this here. It's how does it feel? What's the angle? Where the wire goes? There's a lot of anatomical. It's the art of IR, which is what's really brings me true joy to be able to address that. And then we have to have a conversation with the patient. Say, hey, here are the options. I'm going to make this very simple, but this is something that we generally do. We can do something else to give you hope. And there are some patients that would say, okay, if this is the risks, I'm willing to take it. Or, I had a patient tell me, I would rather die than live one more day like this. And I have patients say, you know what, I want to be the most conservative. If we get to a point where you think it's going to be risky, please don't do it. So it starts with the patient, knowing the risks and benefits, starts with knowing ourselves and our abilities and what we can offer and our judgment. And obviously we build on science. So it is hard when in the forefront because sometimes you're in places that other people have not been in yet. So the science is catching up. But you can build on what we know has been, in other parts of interventions that we can replicate and build on it and share our experiences and learn from it. But it's something that we have to, it's a conversation that I have with every specific patient because that risk versus benefit ratio is different for every patient. So somebody will come and say, hey, can you do this? I can, but is it the right thing for this particular patient? And I have to see the patient. I have to understand their goals. I have to understand, for them, is the benefit outweighing the risk? Maybe for them they are, for somebody else they're not. So just because you do something, should you, is a very important question. And it all depends on how that condition is affecting them and if it's worth it. It's a very, very important thing that I try to teach my fellows, even my trainees and residents and students, what's the right thing to do. And these are very complex decisions.
Yeah, I mean, of course. I mean, especially if it feels like you're the last line of defense. But then, like, to pivot again, there's, the other side of this again, where your research found that most patients would actually prefer, I mean, of course they would prefer minimally invasive options, but just didn't know that they existed. So, you're seeing these patients who you're kind of their only option, but then there's this huge swath of patients as well out there who chances are might prefer your approach and your services, but don't have access or education or don't know what to ask for or who to talk to. How do we think about closing that gap?
That's a very important gap that we need to close because we have to do a better job giving patients options. And I always tell that even my referring physicians, just because you send me a patient, it doesn't mean, I'm just here. IR is the best thing for every patient. I'm not just trying to do procedures. I'm trying to take care of patients. So when we see a patient, we personalize the treatment. Okay, if your goals are X, Y, Z, and these are the expectations, maybe we are the best option or maybe not. So we have to do a better job by educating our referring physicians. I have done several papers and I was honored. Some of them was even award-winning work, characterizing that. What do they want to know? Do they want lectures? Do they want YouTube videos? Do they want outreach? Do they want more science and literature? So I think it's a multi-pronged approach. What I've been doing is I've been advancing the science by showing we have data. So the science speaks for itself. We are getting into the guidelines so people know that these are recognized treatment options, and we are in most guidelines. I like to educate the referring physicians, whether through giving lectures or grand rounds or going to meetings, and also developing online resources for patients and going on podcasts, sharing, developing websites, and I've done even research on multiple tools that patients prefer. And also patients, like I said at the beginning of this, I think the work speaks for itself oftentimes. I've had several patients, for example, uterine fibroids, where they come to me and they say, hey, I read online about this. I saw you doing this procedure and you're a high volume provider in this area. Could you please evaluate me? I talk to them. I talk to the referring physician. I evaluate the situation, take care of them. They come back on follow up and like, this was such a pleasant experience. I'm glad I sought this option. Do you mind if I share this information with my family or my friends or online or this? And I say, yes, please do. So I think we all have to work together to give patients options.
Yeah, for sure. And is there like, we don't have to answer this question, but if it's a complicated, it seems like very often you might have to be, telling a patient something that maybe a referring physician wasn't aware of or wasn't keen to. Like, how do you balance, not trying to undermine the referring physician, for lack of a better term.
Right. No, absolutely. Well, I think communication is key. And what I like to do, and I'm always very respectful with my colleagues and referring physicians, and even if people disagree, and that's also fine. But I always try to do it in a respectful and professional manner. And I also reach out to the referring physician and pick up the phone. Not a lot of people do that. Some people will just send a message or not even communicate. They'll just put a note. But I make it a point to reach out to them and say, hey, thank you so much for thinking about this. Just so you know, these are the options. These are the pros and cons for this versus that. What are your thoughts? So I think by building bridges, I build bridges within people. I wouldn't say the competition, but people who offer alternative treatments, and we all respect each other because we will all be able to take care of patients, but we just want to help the patients get the best options. And like I said, not every for every patient it may be a different thing. So my attitude is not that IR is always the absolute best for every single patient, every single situation, but my attitude is we need to give patients options. And the issue that people have is it's a very common thing. It's basically if you have a hammer, everything is a nail, right? If I only do surgery, then everything is going to be fixable by surgery or not. If I only do IR, everything's going to be fixed by. If I only do medicine, everything's going to be fixable by pills or not. But I try to think outside the box and even challenge myself. Is that really the best option for the patient? What about this? Have we tried this first? Have we done this? And I think once people see the way you practice and you build trust and they respect you because they know you actually care about the patient and you're not just there to pursue turf or do your procedure all the time no matter what, they respect you as a collaborator and as a partner. So I'm not here to do procedures. I'm a physician who is here to treat disease. That's my mindset. I don't offer XYZ procedure. Because then I'm a technician or a plumber. I'm not that. I'm a doctor. So even patients that come to me and we don't have an IR treatment options, they appreciate the fact I can communicate. I can answer the questions. I can explain their disease. I can connect them with people who can help them, or I can, be there for them. So I think if we step back to that gold standard of medicine, the way we all grew up and when we went through medical school, I think that's the best way to go, by really caring about the patient and letting the work speak for itself, and then also advocating.
Yeah, it's. I mean, obviously, it's delightful to hear you say all of that, but especially right after you very briefly touched on some fibroid cases, right? Because when you're working on those complex cancer and fibroid cases, those are like multidisciplinary teams going on, right? You've got a bunch of different people working on that together, yeah?
Absolutely. Yeah, these are complex decisions and complex patients that might need often more than one treatment or sometimes one treatment, or the timing may be different, or if the patient, for example, some procedures are very effective but take time. So is the patient willing to wait? Or some patient may just need a bridge of treatment to menopause because once they get menopause, their issue is going to resolve. Or some patient has cancer. Can we do an IR treatment to cure their cancer? Or can we do it? They're not a candidate for resection, but can we do it to bridge them to transplant or resection? So when people realize that you're there as part of the solution and not just to do something for the sake of doing something, I think you earn the respect. And I respect my colleagues too, and I know they do great work. So I think basically the team approach in medicine is very important. And I think the quality of the work also is very important, and communication is very important.
Because we're talking about communication, we're talking about good medicine. What I really want to touch on now is your work doing research. Did you coin the term moral injury? I know I've seen it before, right? But specifically moral injury versus burnout in the imaging community, right? And I just want to kind of hear your thoughts on that before we dig in too much.
Right. No, I did not coin the term, but I was part of the early group of physicians that applied that term to our field, and I've collaborated with many fantastic collaborators on this topic, Dr. Jeff Schick and others. But basically, there's different things that we have to think about when we think about this area. So burnout, and then moral injury, and then wellness. And they're not all synonymous, but burnout happens when repeated trauma, and usually moral injury, results in permanent damage. And what is moral injury? Moral injury is when you ethically care about something and you have no control when you're trying to do the right thing and you can't do it. So you get this moral injury, and it's repeated stress by the system. Sometimes you work in complex systems where you are trying to navigate the bureaucracy and all these different aspects of care, interpersonal issues and economics and work and reality and business and medicine and all these things. And you're trying to do the right thing, and you have the moral injury of not being able to do the right thing because of all these conflicts. When these repeated injuries happen to so moral injury, so it's just like you get hurt, but you're hurt in your morality, basically. You end up with burnout. You end up becoming disenfranchised. You end up losing interest in your job. You don't have the same satisfaction. You're not as happy. You don't give it 110% anymore. All these things because you feel like you're hurt morally. And then wellness is the solution. So how do we deal with it? We have to apply wellness. And wellness is very important to address because most people, if you go to any conference or any initiative or read something, people always mention the individualistic aspects of wellness, right? The answer to wellness is not doing more yoga or, having a book club or, just getting a good night of sleep. These are good things and we should do
As
them.
great as all of that is.
Yeah, and these are like absolutely individual things that we can do to do wellness. But we also need to have institutional or higher level, wellness initiatives. So, employers allowing time, providing administrative support, giving you the resources to do your job, work-life balance, all these things. So we cannot, yoga ourselves into wellness only. We have to have individual responsibilities as well as organizational or higher level, society level or opportunities. But this is how I look at that whole issue.
Yeah, I mean, I very much identify and empathize with that struggle, right? So, I mean, I used to own a restaurant and wedding venue, where, after the pandemic, I had effectively in order for the business to survive, I had to give mind, body, soul, blood, sweat, tears to it, every second of every day. And once again, I burned out and I don't do that anymore. So you can see the results of it right here on the show. But, it's so tough when you feel like you literally have no choice, right? And I was taking bathtubs every night. I was going to the gym every morning. I was doing every little thing. I was eating perfect, like every little thing within my control to maintain my mental health I had to do. And I would always find that if one thing slipped, right, I didn't get a good night's sleep one night, it would all just crumble like so quickly. And so, I mean, and that's just, people's weddings, right? It's high stakes to the client, but, just another day for me. That's without the added burden of like life and death decisions and patient care. Like I just cannot imagine the physical and emotional strain, which I mean, physical, emotional, mind, body, mind, kind of one thing anyway. But yeah, it's just wild. And so have you been doing like advocacy work, talking about this, or like what is your approach to this balance?
My approach is obviously education and raising awareness. So, it starts in my home institution. When I work with my residents and trainees, I always emphasize that. We've done research. We've published the first and only wellness-related study, to my knowledge, on interventional radiology specifically, just to show, what are the tools that are out there and how we can help our colleagues improve. And obviously on the national levels, I present and I discuss with other colleagues and try to bring initiatives home and, different toolkits that we have in different societies. But it's a struggle because, we have to change the culture. So the culture of medicine is all about working hard and as we should. But it doesn't always, sometimes you don't always get all the resources you need to get your job done, and that can create stress, and people feel guilt and shame because you try and help a patient, but that shouldn't be at the sake of your own mental wellness or health or life. So patients want healthy doctors. Patients want doctors who are in sound minds, who are able to take care of them when they're in good shape. So and especially trainees or residents and students, they work extremely long hours. They're still in training. There's a lot of stresses from bureaucracy and hierarchy and demands. And, in medicine, as you know, there is burnout, there's suicide rates are high. And there is, some folks, unfortunately succumb to drug abuse, different things. So we really have to help our colleagues. And like I said, not only focus on individual responsibility of the physician to do well and be in a good state, but also we have to have our institutions to support, a healthy and well provider. Because if we have healthy providers, we're going to help do a better job for our patients. So I've been trying to advocate and highlight this issue because it's something that people don't always talk about, and maybe it's a taboo in some circles, but it's something that we really need to advocate for, to have a good workforce and to really deliver for our patients.
Absolutely. I mean, I have a keen understanding of the fact that, the entire healthcare establishment is, underwater to some degree, for lack of a better term, right? And yet, but personally, when I have been affected by it, right, my partner had, some neurological problems go down a few months ago.
Sorry to hear that.
Oh yeah, I mean everything's fine now, and it's well controlled. Great radiology team, et cetera, great neuro team. But those first 72 hours, we are bouncing around emergency room to emergency room. We finally get him admitted to neuro. And the first doctor that we get to talk to, is like 50 hours after we've been there, and he comes in. And look, I appreciate that he came to talk to us, but he's like, he sounds like he's a little off of his rocker. And at the end, it comes out, he's like, yeah, I'm on hour 25 of my shift right now because no one else can be here. And it's like, okay, we are in the bucket of trying to count our blessings right now, but as a patient and a loved one, like, that is not what you want to hear. That the first person, like the first doctor that's coming in to talk to you, is just fundamentally unhealthy. It's just not very comforting, I guess, is what I would say.
Of course, and the patients don't want it, and the doctors don't want it, and
Right,
nobody
wants it.
So it's not good for anybody. So I agree with you, and I'm really glad that in organized medicine that other folks are joining our voices and are highlighting this. 10 years ago, nobody was talking about burnout or wellness, but now it's a different story, and there's more initiatives, and obviously a lot more work needs to be done. But I'm very grateful that the conversation is ongoing.
Yeah, I mean, absolutely. And speaking of conversations ongoing, I feel like that is a beautiful place to wrap part one of this episode. So in a special surprise treat, Dr. Makary has agreed to join us for a part two today. And so please join us in a couple of weeks where we will be continuing this conversation and starting to get more into the trenches with some of the more cutting edge work that y'all are up to over there. Thanks for coming on part one. For us, this conversation will not stop, but for our listeners, it'll pick up in a couple of weeks.
Thank you.
Frame by Frame Rethink Imaging is brought to you by Imalogics. Here, you'll find engaging interviews with thought leaders, experts, and patients, sharing stories that showcase the transformative power of medical imaging. To discover how Imalogics is rethinking imaging in healthcare, visit imalogics.com. Be sure to subscribe to Frame by Frame Rethink Imaging on Apple Podcasts, Spotify, or wherever you listen. And from all of us here at Imalogics, thanks for tuning in.